So far, we've gone through pregnancy, the events of the embryo, the development of the fetus. We've talked about what happens to mom. So we've made it. It's time to have a baby now. So we're going to move into a discussion of labor and delivery. So labor is the process where the fetus is expelled from the uterus through the vaginal canal, and we just generally call that giving birth. The onset of labor is determined by a really complex set of interactions of several placental and fetal hormones. Of course, you knew there were going to be hormones, right? Because progesterone inhibits uterine contraction, labor can't actually take place until the effects of the progesterone have stopped. So toward the end of the pregnancy, the level of estrogen in the mother's blood is going to rise very sharply, and that produces changes that overcome the inhibiting effects of progesterone. So the placenta is going to begin to secrete high levels of estrogen, and that's going to cause the number of receptors for oxytocin on the uterus or on the muscle of the uterus to increase. So we're building more and more oxytocin receptors, and cause the uterine muscle fibers to form gap junctions between each other, and that way they have that line of communication, I guess, between each, right? So things can pass from one cell to another through those gap junctions. So oxytocin starts getting released by the posterior pituitary, and that stimulates uterine contraction. Relaxin from the placenta assists by increasing the flexibility of the pubic symphysis, and also it helps to dilate the cervix. The estrogen also stimulates the placenta to release prostaglandins. The prostaglandins are going to induce the production of enzymes that digest away collagen fibers in the cervix and cause it to become very soft. So control of the labor contractions during childbirth, or as childbirth is becoming imminent, occurs in a positive feedback cycle. So contractions of the uterus, or contractions of the myometrium of the uterus, are going to force the baby's head and body down lower into the uterus and put more pressure on the cervix. So the cervix is stretched. So stretch receptors in the cervix then send a stimulus, a nerve impulse, to the hypothalamus. The hypothalamus then causes the posterior pituitary to release oxytocin. Oxytocin then is carried through the blood to target cells which are in the uterus. It binds to the receptors on the smooth muscle and causes the myometrium to contract even more forcefully. So as the contractions get harder and harder, they intensify. The baby's body stretches the cervix even more, because every time the myometrium contracts and pushes, then the baby is being forced down further and further into the bottom part of the uterus. And remember, that's the cervix where all the stretch receptors are. So the more the myometrium contracts, the more oxytocin is going to be released, because those stretch receptors are going to be stimulated. So that is a classic positive feedback cycle. So uterine contractions occur in waves, and they start at the top of the uterus and move downward and eventually lead to the expelling of the fetus through the vaginal canal. True labor begins when uterine contractions occur at regular intervals and usually produce quite a bit of increasing levels of pain. But as the interval between the contractions shorten, the contractions become more intense. Another symptom of true labor in some women is localized pain in the back that's intensified by walking. So if you're having this back pain and you go walking, then if the pain increases, chances are you may be in true labor. But the most reliable indicator of true labor is the dilation of the cervix and what is called the show, which is a bloody discharge. So it's a bloody, mucousy discharge that comes through the cervical canal and, of course, then through the vaginal canal. And once you see that, that is called the show. In false labor, the pain is felt in the abdomen, but it's irregular, so it's not the contractions are not intensifying. Walking doesn't make it get worse, and of course there's no show, and the cervix is not dilating. So true labor is divided into 3 stages. The first stage is the stage of dilation, and that's the time from when labor first begins to the complete dilation of the cervix. This stage typically lasts somewhere between 6 to 12 hours and usually, of course, also has very regular contractions of the uterus, and also under normal conditions will lead to rupturing of the amniotic sac, so the bag of waters burst. If it doesn't, then the physician can take a little hook and go into the vaginal canal through the dilated cervix and hook the amniotic sac and basically tear it, and then you have the rupturing of the amniotic sac. So dilation is complete when the opening of the cervix is dilated to 10 centimeters. The second stage is the stage of expulsion, so expelling the fetus from the uterus. So the time can range from 10 minutes to several hours, is from complete cervical dilation to delivery of the baby. And then the third and final stage is the time after delivery, where the placenta, or what's called the afterbirth, is expelled by really powerful uterine contractions. So we call that the placental stage. It can take anywhere from 5 to 30 minutes, and of course all these times are just averages. The contractions also help to constrict the blood vessels that were torn when that placenta ruptured away from the uterine wall, and helps to reduce the likelihood of hemorrhaging. Most of the time, labor lasts longer with the first babies, typically somewhere around 14 hours. But for women who've previously given birth, the average duration of labor is usually about 8 hours, and it can be much longer though, or it can be much shorter. So the time varies enormously. Because the fetus may be squeezed through the birth canal, the cervix, and the vagina for up to several hours, the fetus is under a lot of stress during childbirth. Now remember, the head is being compressed. The fetus undergoes some degree of hypoxia due to compression of the umbilical cord and the placenta when the uterus is contracting. In response to this stress, the fetus is going to release a lot of epinephrine and norepinephrine from its adrenal medulla. And remember, those are the fight or flight hormones. Much of this, of course, is just to protect against the stresses of childbirth. All the squeezing, the lack of blood flow, right? So these hormones, though, also help to clear the lungs and alter the physiology and make them ready for breathing air. Epi and norepi also help to mobilize nutrients for cellular respiration, so that there's a ready supply of nutrients for that baby, and help to increase blood flow to the brain and the heart. And about 7% of women don't deliver by about 2 weeks after their due date, so they go past when delivery was expected. And when you have a case like this, there's an increased risk of brain damage to the fetus and even fetal death due to inadequate supplies of oxygen and nutrients, because the placenta starts to basically get old and not function as well as it did in the early stages of the pregnancy. So childbirth can be facilitated by inducing labor by giving a drug that is a synthetic version of oxytocin called Pitocin. Pitocin works just like oxytocin. It binds to those oxytocin receptors and increases the rate and the force of those contractions. If that doesn't work, then you can have a surgical delivery of the infant, and that is known as a cesarean section. This would be a good time to talk about a clinical connection. Dystocia is a difficult labor, and this can result from either an abnormal position of the fetus, or the birth canal is just not large enough to permit a normal vaginal delivery. If the fetus is not in the normal position, that's what we call breech presentation. For example, the buttocks or the lower limbs enter the birth canal first instead of the head. This occurs most often in premature births. If the fetal or maternal distress prevents a vaginal birth, the baby can be delivered surgically by making an incision through the abdominal wall. So you do a low horizontal cut through the abdominal wall in the lower part of the uterus. And then it's through that incision that the baby and the placenta are then delivered. So we call this a cesarean section. So popular thought is that Julius Caesar was the first person born with cesarean section, but it's not really associated with Julius Caesar. It's known that the first C-section or cesarean section was described in Roman law about 600 years before Julius Caesar was born. So even a history of multiple C-sections doesn't mean that a woman is going to not ever be able to have a vaginal delivery, but it does increase the chance that subsequent pregnancies and deliveries will be, the baby will be born by C-section. So Julius, sorry, but you don't get credit for this one. Following the delivery of the baby in the placenta is a 6-week period during which mom's reproductive organs and physiology return to the pre-pregnancy state. This period is called the puerperium, and it's a process of tissue catabolism. Remember, catabolism means to break down. So the uterus undergoes this amazing reduction in size as tissues are destroyed, and the process of decreasing size is called involution, and this happens more rapidly in lactating women, in women that are breastfeeding. Women that have just given birth are going to be lactating, but the uterus returns back to normal size much quicker in women that do continue breastfeeding or start and continue breastfeeding. The cervix loses its elasticity and regains its firmness that it had before the pregnancy. And for about 2 to 4 weeks after delivery, women have a uterine discharge called lochia, and it consists of the blood and some serous fluid and, of course, some of the tissues that are being shed as that uterus is breaking down all the excess tissue, and it has to be removed from the body. During pregnancy, the embryo, and then later we call it the fetus, is completely dependent on the mother for everything. So the mother supplies the oxygen, the nutrients, eliminates the carbon dioxide and all the other waste products, protects the developing embryo and fetus against shock and temperature changes, provides antibodies that protect against certain harmful microbes. But at birth, a physiologically mature baby has to become self-supporting. And the newborn baby's body systems have to make a lot of adjustments. The most drastic changes, though, occur in the respiratory and the cardiovascular system. So the reason that the fetus depends entirely on the mother for obtaining oxygen and eliminating CO2 is that the fetal lungs are collapsed or partially filled with amniotic fluid, so they're not functioning for gas exchange, as we learned in the cardiovascular system. The production of surfactant begins about the 6th month of development, and because the respiratory system is fairly well developed, about 2 months before birth, premature babies delivered at 7 months, or around the 7-month period of development, are usually able to breathe and cry. After delivery, the baby's supply of oxygen from the mother is no longer there. Any of the amniotic fluid in the fetal lungs has to be absorbed, and it just gets moved into the bloodstream. But because carbon dioxide is no longer being removed across the placenta and through mom, it builds up in the blood. And those rising CO2 levels stimulate the respiratory center in the medulla, because the CO2 levels lead to a decrease in pH. So there's a temporary condition of respiratory acidosis that develops. So the medulla causes the respiratory muscles to contract, and the baby draws his or her first breath. Because that first inspiration is usually very, very deep, and the lungs don't contain any air, the baby also exhales very, very vigorously, and then naturally evokes a cry. A full-term baby may breathe 45 times or so a minute for the first 2 hours after birth, but breathing rate gradually declines as it approaches a normal rate of about 12 breaths per minute. After the baby's first inspiration, the cardiovascular system has to make some adjustments as well. Closure of the foramen ovale between the atria in the fetal heart occurs at the moment of birth. It diverts deoxygenated blood to the lungs for the first time. The foramen ovale is closed because these 2 flaps of the septal heart tissue fold together and permanently fuse, and then what's left of the foramen ovale is a piece of sort of connective tissue, scar tissue like, that we call the fossa ovalis. Once the lungs begin to function, the ductus arteriosus shuts off due to contractions of the smooth muscle in the walls of the vessels, and it becomes known as the ligamentum arteriosum. Remember, you saw this on the hearts in lab. The ductus arteriosus usually, though, doesn't close completely until about 3 months after birth. If it stays open for a long period of time or it doesn't completely close, that's a condition called patent ductus arteriosus. Remember, we talked about this when we talked about fetal circulation. After the umbilical cord is tied off and cut, then the blood no longer flows through the umbilical arteries. They fill with connective tissue. Their distal portions become the medial umbilical ligaments. The umbilical vein becomes the ligamentum teres, which is the round ligament of the liver. In the fetus, the ductus venosus connected the umbilical vein directly with the inferior vena cava and allowed blood to flow from the placenta and bypass the fetal liver. But when the cord is cut, the ductus venosus collapses and becomes the ligamentum venosum. At birth, an infant's pulse may be very high. It may range from 120 to 160 beats a minute. It can go as high as 180 because obviously there are going to be some periods of excitement with a newborn. After birth, oxygen use increases, and that's going to stimulate an increase in the rate of red blood cells and hemoglobin production. The white blood cell count at birth is very high, sometimes 5 to 6 times higher than normal, but the count decreases rapidly by about the 7th day after birth. When a baby is delivered prematurely, we typically call that a premature infant or a preemie. It's usually a baby who weighs less than about 5.5 pounds at birth. Poor prenatal care, drug abuse, history of previous premature deliveries, mothers that are below the age of 16 or over 35 all increase the chance of a premature delivery. The body of a preemie is not yet ready to sustain some of the critical functions, so its survival is uncertain unless there's medical intervention. So preemies typically stay in the hospital for a prolonged period of time. But the major problem after delivery of an infant that's under 36 weeks of gestation is respiratory distress because of the insufficient levels of surfactant. So remember, the surfactant is not secreted until between the 6th and 7th month in high enough levels for the lungs to be able to fully inflate. So a lot of times the infant that's born premature will have to be put on a ventilator that delivers oxygen until the lungs can function on their own. All right, so now we've had a baby, let's feed it. Lactation is the production and ejection of milk from the mammary glands. If you remember when we talked about hormones with the endocrine system, we learned that the main hormone that promotes milk production is prolactin, which is secreted from the anterior pituitary gland. But even though prolactin levels increase as the pregnancy progresses, milk's not produced because progesterone inhibits the effects of prolactin. After delivery, though, the levels of estrogen and progesterone in the mother's blood decreases, so that inhibition is no longer there, and the prolactin can begin to cause milk to be developed. So the principal stimulus for maintaining prolactin secretion during lactation is the sucking action of the infant. Oxytocin, if you remember, we talked about causes smooth muscle contraction. So oxytocin also causes the release of milk into the mammary glands in an action that we call ejection. So all of this is controlled by a negative feedback cycle. Not surprised to hear that, right? So milk is formed by the glandular cells of the breast and is stored in the mammary glands until the baby begins active suckling. So stimulation of the touch receptors in the nipple is going to initiate a sensory response that causes nerve impulses to be sent to the hypothalamus. The hypothalamus then is going to secrete oxytocin or cause oxytocin to be secreted from the posterior pituitary. It's carried through the bloodstream, just like all hormones, and targets the mammary glands. So the glands themselves have modified epithelial cells called myoepithelial cells. So they're basically like a combination between epithelial cells and smooth muscles. and they surround the glands and the ducts. They have receptors for oxytocin. So when the oxytocin binds the receptors on those myoepithelial cells, then of course the glands are squeezed. So the compression moves the milk from the glands into the ducts where it can be ejected. So this is called the ejection or letdown of milk. Even though the actual ejection of milk doesn't occur for about 30 to 60 seconds after nursing begins, some of the milk is stored in the lactiferous sinuses, or little enlarged parts of the duct near the nipple. Stimuli other than suckling, though, such as hearing your baby cry, or stimulation of the genitals during sexual contact, or even warm water in the shower, can also trigger that oxytocin release, and then milk is ejected. Very often lactation blocks the ovarian cycle for the first few months after delivery if the frequency of suckling or feeding the baby is about 8 to 10 times a day. But this effect is inconsistent, and ovulation commonly precedes the first menstrual period after the delivery of a baby. So you may have heard the old wives' tale that you can't get pregnant when you're breastfeeding. Well, there's been a lot of women that have heard that old wives' tale and thought that was true. It may be true for a lot of women in the early months of breastfeeding, but it is not a reliable form of birth control. So you can't be certain that you're not fertile. So again, even though breastfeeding is a benefit in that it helps the uterus return back to its normal size, and it can also block the normal menstrual cycle, it is not reliable for birth control. I know I've repeated that, but I wanted to make sure you hear that. So let's talk about some of the benefits of breastfeeding. So obviously, breastfeeding is nutritional. So human milk is a sterile solution that contains fatty acids and lactose, amino acids, minerals, vitamins, and water that are ideal for baby's digestion, but also for brain development and growth. But breastfeeding also has other benefits. So there are several types of white blood cells that are present in breast milk, neutrophils and macrophages that can serve as phagocytes in the immature immune system of the baby. Macrophages also produce lysozymes and other immune system components. Plasma cells, which remember develop from those B lymphocytes, produce antibodies against specific microbes, and T cells kill microbes directly. So all of this is coming from breast milk. There's also a decreased incidence of diseases later in life in infants that are breastfed, because breastfeeding provides infants with a slight reduction in risk of developing lymphoma, heart disease, allergies, respiratory and gastrointestinal infections, ear infections, diarrhea, diabetes mellitus, and meningitis. And then there are several miscellaneous other benefits. It supports optimal growth. Breast milk, human breast milk, is made for human infants. So it's the optimal food for growth. It enhances intelligence and neurological development. And it also fosters a mother-infant relation because it's established very early and allows for prolonged contact between them. Compared to cow's milk, the fat and iron in breast milk are more easily absorbed, the proteins in breast milk are more easily metabolized, and the lower sodium content is better suited for an infant's digestive needs. Premature infants benefit even more from breastfeeding because the milk produced by mothers of premature infants is especially high in protein, and especially with the premature infant having an even less mature immune system benefits even more from the immune cells that are a part of that breast milk. And finally, a baby is less likely to have an allergic reaction to mother's milk than to milk from another source.